Hi, my name is Aaron Phipps, and I was assigned the lower limb case study 3. The patient is a 32-year-old female. She came in complaining of pain in the center of her right buttock, and she was experiencing occasional numbness and tingling in posterior thigh and continuing down into her lower leg. The patient is pretty active. She runs regularly, and she also plays for a semi-professional hockey team. She did mention that she thinks her right leg is weaker than her left leg. During the physical part of the examination, the patient did experience pain in the gluteal region when deep pressure was applied. She also experienced pain with medial rotation and adduction of the hip. When deep pressure was applied to the posterior thigh, she experienced numbness and tingling. The cross straight leg raise test was negative, um, and there was no difference found in the strength of muscles between the left and right leg. An MRI of the lumbar region was done and it came back normal. So I have 3 possible diagnoses for this patient, and the first is chronic hamstring tendonitis. Symptoms of chronic hamstring tendonitis include a sharp burning pain in the posterior thigh, muscle and joint weakness, and also muscle and joint stiffness. Some common risk factors with this include a lot of running, an imbalance of muscle strength between the left and right leg, and also older age. The hamstring muscles are located in the posterior thigh, and there is 3 of them. The more medial muscles are the semitendinosus, which sets right on top of the semimembranosus, and then more laterally is the biceps femoris. These muscles work to extend the hip and flex the knee, and medially rotate the hip when the knee is bent. So this hamstring tendonitis is caused by overuse or degradation of the tendons. This causes tiny tears in the muscles, which leads to inflammations and pain. So diagnosis of chronic hamstring tendonitis would most likely be done by part 1, a physical examination in which any activation of the hamstring muscles is going to cause pain, and then they would know to take an MRI. And the MRIs are pretty good at diagnosing tendonitis. So moving on to the second possible diagnoses, we have the herniated lumbar intervertebral disc. Some symptoms of a herniated disc would be sharp pain extending from the buttock down the back of the leg. Patient would experience numbness and tingling and a possible weakness in the affected leg. Some risk factors. Males are actually more susceptible to this. Lifting heavy weights repetitively would increase your likelihood of getting this. Repeated stress on lower spine in any form, frequent driving, and a sedentary lifestyle also contribute to this. An intervertebral disc is made of a core called the nucleus pulposus and the outer ring called the annulus fibrosus. So in a herniated disc, the nucleus pulposus, the jelly-like substance, is going to actually push out of the outer ring, and this is going to cause pressure on the spinal cord and nerve roots in the area. So the 2 causes, or common causes that I found, were 1, aging. As people age, the intervertebral discs actually lose water content, which causes shrinkage. And then the second being trauma. Just any kind of trauma to the lower spine can cause this. A herniated lumbar intervertebral disc will usually be diagnosed by first a straight leg raise test, in which the patient would lie flat on his or her back, and the examiner would lift one leg, the affected leg, keeping it straight, and if the patient experiences pain, that's a positive result. And then secondly, to confirm that, they would most likely do an MRI of the lumbar region, um, in which you can see right here, that is the herniated disc. The third possible diagnosis is piriformis syndrome. So some of the symptoms with this syndrome is going to be a dull pain in the buttock extending down to the back of the leg and sometimes to the foot, and also numbing and tingling sensations. So the pain would be described as sciatica, just as with the the herniated lumbar disc. Some of the risk factors for this are, well, females are more prevalent to have it than males. Uh, Prolonged sitting can put you at risk for this. Athletes sometimes have it, which our patient is an athlete. And anatomical variation, which I'll get to in a few slides. Piriformis syndrome is caused by the piriformis muscle compressing down onto the sciatic nerve, causing the pain and numbness that patients feel. Here we have the piriformis. It runs diagonal across the sciatic nerve. Actually originates on the anterior surface of the sacrum, works its way through the greater sciatic foramen, and attaches at the greater trochanter of the femur. So it is superior to the gemellus muscle here. And then if we keep going down, we have the obturator internus and the inferior gemellus muscle. And all of these muscles work to laterally rotate and abduct the hip. So here we have the sciatic nerve and its branches. After it runs past the piriformis, you can see it branches off and innervates these muscles. And then as we get down to about the knee, it splits off into the tibial nerve and the common peroneal nerve. So anatomical variation plays a huge factor in whether patients experience piriformis syndrome or not. So in this image, we can see this is what we want right here, with the sciatic nerve running below the piriformis muscle. And here we have it the sciatic nerve partially running through the muscle. And in this image, it is completely running through the piriformis muscle. So in these two examples, these patients would be most likely to experience piriformis syndrome. Usually to diagnose piriformis syndrome, we start by ruling out other causes of sciatica. So we might use the straight leg raise test, which if that came back positive, we would know it's not piriformis syndrome. It's important to note that MRIs cannot detect piriformis syndrome. But a positive result with the flexion, adduction, and internal rotation test would lead to a diagnosis of piriformis syndrome. So now that I've gone through all the possible diagnoses, I'll just run back through each one and discuss whether or not I think she has it and my reasonings for that. The first is chronic hamstring tendonitis. During the exam, they did not find any difference between her right leg strength and her left leg strength. So for that reason, I ruled it out. Second is the herniated lumbar intervertebral disc. This one was the easiest one to rule out because in the exam, she had an MRI, which came back normal, and the SLR test was negative, which both indicate that this patient does not have a herniated lumbar intervertebral disc. And then lastly, I do think she has the piriformis syndrome, or I would diagnose her with piriformis syndrome. She meets two risk factors outright. She's female and she is an athlete. Um, we don't know about the anatomical variation, but that could play a part in it. She received a negative SLR test, which rules out um, other sciatica causing things. And lastly, she felt pain during the examination when her hip is medially rotated and adducted. So um, I have here some treatment options for piriformis syndrome. The first would be stretching. Second, icing to reduce inflammation. NSAIDs can be taken to do the same thing, reduce inflammation. Botox was a different one that I saw, where they would inject Botox in order to try to inactivate the um, piriformis muscle, try to get it to stop compressing on that sciatic nerve. And then lastly, the surgical intervention is very rare, but sometimes is required in severe cases. And in that, they would go in and remove some of the piriformis muscle. Thank you for watching.